Right. Hope you're comfortable because we're going to talk about the clinical presentations of lung tumors in general. Importantly, we need better screening methods to detect lung cancer at an earlier stage. The tragic and unassailable fact is that many people are asymptomatic until they're stage 3 or 4, beyond surgical resection and likely to die. So these symptoms in 4 major categories are ones that primary care physicians must have their ears attuned to be able to suspect the possibility of an adenocarcinoma, squamous carcinoma, small cell carcinoma in a person who is at risk. Who's at risk? Smokers and older people. So let's look. Any local symptom. When you have a change in a cough or a new cough, chronic cough, smoker's cough from chronic obstructive pulmonary disease, a change in that cough, in its frequency, its severity, its color, the presence of hemoptysis because at some point a mucosal surface is being ulcerated in the respiratory tract when we cough up blood. Most common cause is simply bronchitis, but neoplasms arising from the bronchi can also cause bleeding. Wheezing due to obstruction of the bronchus by tumors, lobar pneumonias or apparent atelectasis that does not resolve after appropriate treatment, and abscesses that do not resolve after appropriate treatment. So these are all local effects of the tumor. As the tumor invades locally, you can get chest pain as it invades certain structures in the chest wall. Pleural effusions give you difficult breathing. Carditis or cardiac tamponade or dysrhythmia as the tumor invades the pericardium. SVC syndrome is facial swelling and congestion due to obstruction or thrombosis of the superior vena cava. So the tumor is extrinsically pushing and narrowing the SVC, resulting in venous congestion proximal to the obstructing point or actually inducing a thrombosis. The Horner syndrome is ptosis, meiosis, anhidrosis, very poetic, and it's due to invasion of cervical sympathetic nerves by tumor. Hoarseness can develop simply because a vocal cord is paralyzed because the tumor is not invading the vocal cord but invading the recurrent laryngeal nerve. And a Pankos syndrome is defined as shoulder and arm pain due to invasion of the brachial plexus by a malignant neoplasm, and it's most typically a upper lobe neoplasm, high in the lung, that grows out of the lung into the brachial plexus. Metastases can be anywhere, but the ones that are easiest to detect clinically are cervical and supraclavicular enlarged lymph nodes. So when you're doing a physical exam, palpate deep along the cervical region in both sides of the neck and the supraclav regions to detect any firm lymph nodes, and then do the appropriate workup if you find some. Paraneoplastic syndromes are the topic of the next slide. Paraneoplastic, para alongside a neoplasm. So these are strange and unusual syndromes that consist of symptoms or signs that cannot be explained by the presence or direct invasion of structures by tumor. So here are the examples. By the way, maybe 1 in 10 to 1 in 20 people with cancer do have a paraneoplastic syndrome, and they can be the first thing that one sees. So very critical. Someone who has low or decreased amount of urine, decreased volume of urine, oliguria, associated with a low serum sodium concentration. They may be making antidiuretic hormone in an inappropriate excessive amount. Those are usually small cell carcinomas. The Cushing syndrome resulting from excess ATH made by small cells will give the characteristic central obesity pattern, rounding up of the face, and suffusion of the vascular structures in the face, or plethora. That's the Cushing syndrome, and the tumor is making the ACTH. Squamous cell cancers are the ones most likely to make parathyroid hormone-related protein. It's not PTH exactly, but it's so close that the bones interpret it as parathyroid hormone, and that bony effect causes resorption of bone, release of calcium from the bone, and ensuing increased calcium concentration in the blood. So that's the exceptions, squamous cells. Small cells and carcinoid and some large cell neuroendocrine carcinomas, note they all have a common origin in a neuroendocrine cell, can cause the carcinoid syndrome, which is excess vasoactive substances being made by the tumor. And people with this syndrome will have flushing due to prominent vasodilation, diarrhea as it affects the GI tract, and or cyanosis as they have vasoconstriction, reactive vasoconstriction. Another very strange paraneoplastic syndrome is called HPO. That's not a movie channel. It's hypertrophic pulmonary osteoarthropathy, and this is most characteristically seen in adenocarcinomas. And you get this combination of arthritic enlargement of the distal interphalangeal joints, clubbing of the fingers, loss of the angle between the fingernail and the periangual skin, and a periostitis, or an inflammation of the long bones causing pain, maybe with joint effusion. So it's kind of an odd conflagration of bone and arthritis and fingers, all perhaps a clue to the presence of an underlying adeno. And then there are small cells that make antibodies to the voltage-gated calcium channel, which results in tumor-related myasthenia, which we call the Lambert-Eaton syndrome. So familiarity with these kind of unusual groups of signs and symptoms can be very important for an early diagnosis. Let's illustrate them. This gentleman has a very round face and marked congestion of the vessels in the face. Another patient here showing a markedly protuberant abdomen with a lot of subcutaneous fat and these reddish-colored abdominal striae of the skin. These are typical features of cortisol excess here and here. So this is the Cushing syndrome. By the way, you'll never see moon faces on a NBME exam. It will use a English description saying the face has increased subcutaneous tissue resulting in a round contour. That's what the kind of things they'll say. Hypertrophic pulmonary osteoarthropathy, excuse me. So here's your periostitis, elevation of the periosteum above the level of the cortical line here. So you see just a thin space, and that outer rim is the periosteum. Here are the clubbed fingers, loss of the angle between the nail and the skin. Notice it's almost a flat line there instead of a gull wing going down and back up. What about metastatic disease? Well, the lung catches more metastases than any other organ. And doesn't that make sense? All the lymphatic and venous blood ends up going to the right heart and filtered in the pulmonary capillaries. So it's a breeding ground for metastatic disease. And actually, anytime you have a solitary lung mass, there's always the possibility that it's a metastasis. So the first thing is, don't hone in on the lung mass to the exclusion of the rest of the person. Do a complete history and physical, and the simplest question is, have you ever had cancer anywhere? And sometimes that will lead you right to why the lesion in the lung is most likely a metastasis. Here are the features to consider. None of these are ironclad, but they are helpful. If there's a history of primary cancer in another organ, that argues strongly that the nodule in the lung is metastatic, and that's because any organ harboring a cancer can metastasize to the lung except for primary CNS malignancies. The probability that any lesion is metastatic is proportional to the number of separate tumor masses in the lungs. So, if there's one mass in the lung, it's not as likely to be metastatic as if there are 7 separate masses. Okay? Does not mean that a primary lung cancer can't have a dominant mass and a sort of a satellite mass nearby. That's 2 masses, can still be primary lung cancer. But the more that you have, and especially if they're in bilateral lungs, the probability of metastasis increases. Also, metastases are usually peripheral, but compared to primary cancer, can be central or peripheral. Especially adenocarcinomas are known to present often in a peripheral location, so primary adenocarcinoma can look just like a solitary metastasis. The most cost-effective maneuver for distinguishing primary lung cancer from a metastasis is to do a CT-guided fine needle aspiration, give the cells to the pathologist. We can analyze them morphologically, immunohistochemically, and determine in almost all cases whether the tumor is a lung tumor or a MET. PET scans are very useful to distinguish benign from malignant pulmonary nodules, but they do not distinguish primary versus metastatic because both primary cancer and metastatic cancer are likely to be PET positive, so not useful in that situation. So before we leave lung neoplasia and finish this lecture up, I wanted to give you a summary slide. This is my best shot at giving you a concept map. If you take all the lung neoplasms in the world, you can put them into one of these 3 orange boxes. It's a small cell carcinoma. It's a non-small cell carcinoma. These are both epithelial because they're named carcino, and it's a non-epithelial tumor. That's it, one of those 3. So let's dispense with the non-epithelial tumors of the lung, which are very much less common than these 2 boxes. Lymphomas, mostly B cells, and rare sarcomas. That's it. For malignant neoplasms now. We're talking malignancy here. For small cell, it's a pretty short story. The most common tumor is a poorly differentiated neuroendocrine cell tumor that we call small cell carcinoma. Under that, remember that there are 2 other tumors from the same cell type, but they're named differently because they're not as poorly differentiated. So if it's well-differentiated neuroendocrine cell tumor, it's a carcinoid. Moderately differentiated neuroendocrine cell, it's an atypical, and these are poor. So that dispenses with our neuroendocrine tumors. Now move into the big bad box, the non-small cells. This is a wasteland, but it's not an unnavigable, yes, let's say that, unnavigable wasteland. Bronchiolar or bronchiolar epithelial cells, here are the types. Just 3, really. Adeno, forming glands, squamous, looks like skin, and poorly differentiated tumors that are large cell and not small. Those are the 3 categories. Under the adeno, most of them have glands and destructive fibrous stroma, so the lung architecture is removed and destroyed by the advancing tumor. It's replaced by the tumor. That's the usual adeno, but there is this subtype where the cells of the tumor grow along architecture. You can still see alveolar type spaces and terminal bronchioles. That's our bronchiolo-alveolar carcinoma, which is the best prognosis carcinoma you can have in the lung. Squamous cell carcinoma and poorly differentiated large cells are really 3 lines of differentiation. We just can't name them because we can't see the differences, so we just call them poorly differentiated large cell. But if we could see the subtle differences at ultrastructural level, These are either a squamous that has gone unrecognizable, they're a gland-forming tumor that has so poorly differentiated it's unrecognizable as a gland-forming adenocarcinoma, or it's a neuroendocrine cell tumor that is poorly differentiated but hasn't become a small cell, so it's a large cell neuroendocrine. These we can nail by immunohistochemical stains. We don't know for sure whether the biologic behavior of large cell neuroendocrine carcinomas is different from the other poorly differentiated large cell carcinomas. That is awaiting more prospective and investigative trials. So that's my concept map. I hope it's helpful to you. Next to last topic, pleural tumors. So what do we mean by mesothelioma? Well, mesothelial cells are cells that line all the smooth surfaces in the thorax and in the abdomen. So mesothelial cells line the parietal and visceral pleura, they line the pericardial sac, they line the peritoneum. Mesothelial cells are ubiquitous. And a tumor arising from mesothelial cells is called a mesothelioma. In the chest, they either can come from the visceral or parietal pleura, but their growth pattern is one that progressively moves along the pleural surface and encases the lung like a rock. That's a mesothelioma. Definitely related to asbestos exposure, manufacturing, mining, shipping. Heavy exposure, that is years of asbestos exposure, usually an occupation that is dealing with aerosolized asbestos fibers. The lifetime risk is about 10%, with a long latent period from the onset of exposure to the detection of a malignant mesothelioma. Therefore, asbestos workers have a 5 times increased risk for lung carcinoma. Now let's get this straight. 5 times increased risk for carcinoma, which actually is numerically greater than their risk for developing mesothelioma. And if you work in asbestos and smoke, the synergism gives you a 60 times increased risk for lung carcinoma compared to someone who doesn't smoke and is not exposed to asbestos. So that's a double lethal whammy. Now, are asbestos workers have increased risk for mesothelioma? You bet, but they actually have a higher risk compared to baseline for lung carcinoma. The kicker is that if you have a mesothelioma, you almost always have been exposed to asbestos, whereas most people with lung carcinoma have not been exposed to asbestos. So I hope these associations are clear in your mind. How do we know someone's exposed to asbestos? We can see the markers within the pulmonary parenchyma called asbestos bodies, which are fibers of asbestos coated by an iron-containing proteinaceous material that forms these little dumbbells, long dumbbell-shaped things in the lung, and fibrous pleural plaques that are not tumors, they're not neoplasms, they're just a fibrous reaction to the presence of asbestos in the lung. Molecular genetic-wise, we see deletions in most mesotheliomas and p16 mutations in about a third. And there's some good laboratory evidence that simian virus 40 is an inducer and possibly an early pathogenetic step in mesothelioma. We do see viral DNA sequences from this virus in 70% of pleural mesotheliomas. We also know that the virus can inactivate the tumor suppressors p53 and retinoblastoma, and therefore may contribute to the development of mesothelioma by that mechanism. That's a may. It's a laboratory finding, hasn't been well documented in humans. So here are the nasty mesotheliomas. This one is a particularly nasty one. This is all that's left of the lung, this reddish-brown parenchyma. All of this brown, tan, white rind is malignant mesothelioma growing along the pleura invading the lung, invading the mediastinum right here, and even invading the pericardial sac. So nasty advanced tumor, obviously an autopsy picture. And here is another one, not quite so severe in volume, but look where it's going. All the way around the lung, all the way around the lung, even in the interlobar septa here and into the mediastinum and surrounding the pericardial sac. So it's a very invasive, destructive tumor. The two histopathologic types are mixed epithelioid and sarcomatoid. So here is the spindle cell sarcomatoid element of this mesothelioma, and the epithelial component that appears to form glands is marked with brown by an immunohistochemical stain with an antibody against calretinin. So this is one of the antibodies we used to verify the presence of mesothelial cells as opposed to just bronchial epithelial cells. And then the more challenging ones are like this, where it's all epithelioid and no stromal sarcomatous component. And so your differential is this an adenocarcinoma, a gland-forming bronchial epithelial tumor, or is this a malignant mesothelioma that only forms epithelial structures in glands? Immunohistochemistry generally resolves that problem. And of course, there are the ever-present lawyers who are willing to pounce on anybody who's been diagnosed. And these guys here up in the Northwest, the best ones, have obtained over $400 million for our clients from the impoverished companies who gave them their asbestos in the first place. They, like the ophthalmologic surgeon who works only on the retina, they are solely focused on asbestos litigation. One more neoplasm of the pleura, we call it a solitary fibrous tumor. Here it is in a 70-year-old woman. So here's her vertebrae, here's the mediastinum, and here's this massive pleural thing. And 3 years later, 3 to 4 years later, this tumor is 3 times its original size. Trust me, you'd have to do the CAT scan, all the levels, but it got really big. Looks nasty. However, when you take it out, it was 24 centimeters diameter. It weighed 2.3 kilos, but they took a knife and sliced it right down the middle. So this is the outside surface. This is the cut surface. And this monstrous thing is a benign tumor. It is simply composed of lots of fibroblasts making collagen. This isn't even a mesothelial tumor in cell of origin. It's benign. It certainly causes havoc when it gets this big by compressing things, but it is not related to asbestos. It is just a big, bad, benign thing, and we don't know what causes it. Moving to the separate topic of lung transplantation, we're almost done. Hang in there. Here we go. There are a few non-neoplastic lung diseases that have a terminal prognosis. Bad, bad, bad. Most of these are bad COPD or idiopathic pulmonary fibrosis, both of which may terminate in such a fibrotic lung that the person is going to be dependent on a ventilator for survival. At that point, they are considered eligible for a lung transplant. The beautiful thing about lung transplant is that some donors can donate left and right lung, and in many cases, a single lung transplant may be adequate for survival. So that's the 2-for-1 beauty of being an organ donor. Most common indications, COPD with secondary pulmonary hypertension, idiopathic pulmonary fibrosis, cystic fibrosis, although we're getting better and better at treating people with CF, so this is less and less a indication for lung transplant, and pulmonary hypertension with right heart failure. If you have this, you are fatal without a transplant. Cystic fibrosis right now, median survival is 35 to 40 years. If you have IPF, you're going to live about 3 years without treatment, so you need a lung. And there's a 50% 5-year survival in COPD after the pulmonary artery pressure is over 30. So these are all reasonable indications. Pathology of complications. What happens to people after the lung transplant? Well, infection early on, bacterial. Within the first year, more fungus and viral infection. And all these people need prophylaxis against cytomegalovirus and pneumocystis because they're immunosuppressed. And these organisms love to jump into the lungs of people who are immunosuppressed. Rejection of the transplant is manifested in two phases. Acute rejection is dyspnea with infiltrates in the lungs, lots of inflammatory infiltrate around bronchi and blood vessels, and those people are not going to keep their lung. Chronic rejection is a slower developing situation in which treatment can prolong the durability of the lung transplant. We notice some degree of chronic rejection in all transplants at 5 years, and it is the diffuse inflammatory infiltrate and bronchiolitis obliterans. What is bronchiolitis obliterans? Just what it says, obliteration of a bronchiole by a mixture of fibrous tissue and mononuclear cell inflammation. So when this is happening in multiple bronchioles, the alveoli and terminal bronchioles that are feeding into that bronchiole are rendered useless as far as inspiring oxygen into them. So when this happens diffusely, you're going to have a dysfunctional lung. So what's the overall survival post-transplant? 80% 1 year, 50% at 5, and a full quarter of the people still alive at 10. That's a lot better than the prognoses listed on the previous slide. So when you're out in the wild, it is a rough society out there, people competing. Watch out for the big dogs here. Good night.